Good morning, everyone. Let me just get myself situated up here. It's really an honor and a pleasure to be here with you all today. This is actually my first time to Louisville or Louisville or Louisville. Apparently, there's multiple ways to say it. Hopefully, all of them are correct. But unfortunately, like most of my trips, it's an in and out visit. But just in the last, I guess, less than 24 hours that I've been here, I've learned that Diane Sawyer's from Louisville, given the very big picture that she has on one of the buildings downtown. And then obviously that Muhammad Ali has ties to the city. But before I begin, as Sandra said, I am a University of Michigan alum. And when I accepted the invitation to come and speak here in Louisville, little did I know that this little game called the March Madness Championship game in basketball was actually going to be played featuring my alma mater, University of Michigan, and this little known basketball team in Kentucky known as the Louisville Cardinals. And what I really was really hoping as I was watching the game last Monday was that I'd be able to come in and share my condolences as I shared this slide with you all. But for the few of you that might have watched the game, I'm sure nobody here saw the game last Monday. Unfortunately, that's not the case, and I just have to eat crow and just say congratulations to the Louisville Cardinals for a very well played game. Really, really well earned game for you all, so congratulations. So just a quick overview of what I'll be covering today. I'm going to go through some context, but just covering some overall numbers as it pertains to our health status in the US and the health issues and go through unpacking those numbers. Then I'm going to transition into a discussion of why this even matters for us. And I'm going to make a call for action for us to actually go back to our roots of what we know as it pertains to health and public health and how to improve population health. Afterwards, I'll transition into a discussion about some promising approaches that I've come across in my role at the Robert Wood Johnson Foundation. And I'm going to transition into new frontiers in science that cover areas that show promise for how we can advance our work as it pertains to population health. And lastly, I'll call out what I think is the big elephant in the room before I open things up for Q&A. Now, I'm sure that there are going to be many in the room that will have heard many of the things that I'll be covering in my talk today. And just consider this a refresher and a moment of invigoration for all of the great work that you are doing. So let's discuss our health in the US. When it comes to spending, we can actually brag that we are number one. Based on numbers in 2010 alone, the US spent $2.6 trillion. That's a trillion, not billion, $2.6 trillion in healthcare, which reflect roughly 18% of our gross domestic product. And this is a number that actually increased by over $1 trillion in just one decade alone. But despite being number one in the world in spending in healthcare, we are not the healthiest people in the world. And in fact, trends are starting to show that we're going backwards and that we're potentially going to be facing a situation where we're raising a generation of children that will live sicker and die younger than their parents. Now, to be more specific, the US spends on average about $8,000 a person, which is over 2.5 times greater than the average amount spent in the rest of the developed world. Now, if we were to plot that, what our healthcare spending should buy us as it pertains to life expectancy, what we would see is that we would be second only to Japan in the world, who tends to have the highest life expectancy. However, our actual life expectancy does not buy us that much health, and we see that it's much lower than we could expect it to be. And it's actually 4 years lower than what our expenditures say it should be. Another indicator of our nation's health, which is infant mortality, which measures the rate of death for children who die before reaching 1 year of age. And here we see that over time, we've been losing ground as we compare to other industrialized nations. Now, in 1980, we ranked 18 in the world as it pertained to infant mortality. In just a little over 20 years, we fell down to number 25. And if we were to plot these numbers again, based on the numbers in 2010, we're down to 31. But while these numbers give us an overall picture of the health of the US, they don't tell the entire story. and it's probably a more sobering story. The story that shows us that there are significant disparities in health based on just where we live in this country, where the health of individuals that live predominantly in the South and Southwest of our nation often lags behind the health of those in the Northeast and the Midwest. And this pattern even persists within smaller units of geography as well. Here, demonstrated showing a map of the DC metro system, where we see that traveling just 10 miles along the orange line, that there is, in a 10-mile span, an 8-year gap in life expectancy between those that live in DC proper versus those that live in the suburbs of Fairfax County, Virginia. In addition to the geographic disparities in health, we also know that there are significant disparities of health by gender and by race, where on average, women live longer than men and whites live longer than blacks. And these gender and racial disparities are unfortunately a common and consistent narrative. A new twist to this narrative, however, is the trend that we're starting to see where life expectancy is actually already declining for certain groups. A couple of key studies have just come out in the last year that have shown that life expectancy overall has declined for white men and for white women who do not have a high school diploma. Women have lost 5 years of life expectancy, and men have lost 3 years. Again, those that do not have a high school diploma. Even more recently, when you look at overall mortality rates by counties, the picture is particularly troubling for women, where in just a 10-year period, Kindig and Chen, in this study published in Health Affairs, found that 43%, let me repeat that, 43% of the counties in the United States, there was a little over 3,000 counties in the United States, mortality rose for women, whereas only 3% experienced an increase in mortality for men. And what the researchers found was that lower education, higher rates of smoking, and living in the South and West were all associated with those higher mortality rates. So now that I've pressed you all with the less than rosy picture about health in the US, why does this all matter and why should we even care? Well, our trends should not be taken as an inevitable destiny because we know that at least 75% of our healthcare costs, 75% of disease and disability is totally preventable. And if over 3/4 of our healthcare costs are preventable and therefore 3/4 of disease is preventable, then we should start realizing that as a nation, we cannot continue spending over 95% of our healthcare dollars treating illness once it occurs. And we can't continue treating individuals like we're just a sum of our collective parts. Though we are shifting our healthcare lens to a prevention lens, it's going to be a challenge if primary care physicians continue to earn half of what their specialty counterparts earn in this nation. Now, the Affordable Care Act, more affectionately known as Obamacare by some, is an effort to address some of the issues in our healthcare system, and it'll take us some time to really understand the impact that it's going to have on not only our system, but on healthcare in the long run. In the meanwhile, however, healthcare is not the only one to blame and should not bear the burden for what is not working within our health in the United States. Our public health system, too, has operated for a very long time in our silos, where we segment disease, conditions, and functions of our system. And we very rarely coordinate and understand that a much coordinated approach is necessary to achieve fundamental improvements in health at the population level. Similarly, because of the epidemic of chronic illness in our country, we have focused a fair amount of our energy and attention to getting people to adopt healthier behaviors, which is a completely and totally necessary thing for us to do. However, all of that effort is going to be in vain if we ignore the context and the environment that shape individual behaviors and decisions in the first place. So given our health issues, some have argued that we need a new vision of health or a new vision of public health. And I would argue that we just need to go back to our roots and do what our early leaders of public health said we should do to promote and preserve health. C.A. Winslow, who was a respected public health practitioner and was the first chair of the Yale School of Public Health, defined public health as follows. He said that public health is the science and art of preventing disease, prolonging life, and promoting health and efficiency through organized community effort for the sanitation of the environment, the control of communicable infections, the education of the individual and personal hygiene, the organization of medical and nursing services for the early diagnosis and preventive treatment of disease, and for the development of the social machinery to ensure everyone a standard of living adequate for the maintenance of health, so organizing these benefits as to enable every citizen to realize his birthright of health and longevity. Now, somewhere in our history, we forgot this second half of our definition of what public health is. So going back to our roots recognizes a definition that doesn't isolate an individual from the context and the environment, but acknowledges that our health is a sum of our collective experiences and exposures, both within and outside of our control. And going back to our roots also recognizes that not only do access and quality of care and the behaviors we engage in matter for our health, but other things also matter for our health. And that these other things, such as poverty, education, housing, matter more for our health, and that improvements in these conditions alone would translate in improved health for the populations. And finally, going back to our roots means that we work from a framework that recognizes that health happens where we live, learn, work, and play, and therefore that the places we live do matter for our health. So if we want to be healthy, we need to make the places that we live healthy. So it's always easy to point out the problems and what we're doing wrong. But I'm happy to say that I do have some bright spots to point out, to highlight what folks are doing in the field that can move us towards improving our population's health. The first example comes from an article that Atul Gawande wrote 2 years ago in the New Yorker magazine called The Hotspotters. And in this article, Gawande centered and highlighted the work of the Camden Coalition for Health Providers. How many of you all are familiar with the Camden Coalition's work? Okay, a few of you. Now, in the article, Atul Gawande highlighted how in Camden, they realized that just 1%, 1 out of 100 of their patient population accounted for a full third, 1/3 of the medical care costs in the city. And what they decided to do to address those issues was by taking healthcare to where those individuals are and addressing the needs of what they termed super utilizers to significantly reduce healthcare costs, and not only addressing the healthcare needs, but also their social needs as well. Now, this model should be familiar to some of you, actually, given an article that just came out yesterday in USA Today that highlighted that the University Hospital here in Louisville is actually implementing a similar model that's based off the Camden Coalition. And in that story, they focused on a patient called Dennis Manners, who in just a 2-year period here in Louisville racked up over $600,000 in healthcare costs, over 337 visits to the emergency room. 2 years, $600,000, one patient, 300 visits to the emergency room. And what they said in the article was instead of treating him and streeting him, as is commonly done in emergency rooms, they highlighted how the hospital's new population health management complex case program connected Mr. Manners not only to a primary care physician, but also to a neurologist to treat his seizure disorder, to substance abuse treatment, which was a major driver for why he was coming into the emergency room to begin with, and helped him get an apartment. Total cost for connecting him to all these services, $6,000. And how many visits has he had to the ER since the 8 months he started the program? Only 3. Now, many see promise in the model for the system, so much so that back in 2012, just last year, the Camden Coalition itself received a Healthcare Innovation Challenge Award from the Center for Medicaid and Medicare Innovation to help replicate the model in 4 different cities. Now, another example of the healthcare system branching outside the traditional box comes from a program called Health Leads, which was developed in 1996. And what it does is it embeds college students within hospitals and clinics to attend to the basic resource and social service needs of individuals and families who are often living in poverty, and that we know are major drivers of poor health. And what happens in these hospitals and clinics is that doctors prescribe social service needs in the same way that they would prescribe medication. So they prescribe things like food assistance, daycare, job training, et cetera. And the students who work as the healthcare advocates for the patients make sure that each of the individuals, after receiving the prescriptions, are actually able to get their social needs services met. Now, this program has promise on multiple levels. First of all, it frees up both healthcare personnel time as well as social work time in order to address the specific need that individuals are presenting with in the clinic to begin with. Second, it attends to very important social factors that we know are often standing in the way of people getting healthier in the first place. And third, which is probably one of the very promising aspects of the model, is that it's training a cadre of future health professionals that understand the very important relationship between social factors and health. Now, these are just two examples of the many examples I could have gone on and on regarding how healthcare is expanding beyond its traditional box and starting to see the responsibility that it has for taking care of community at a broader level. And we expect to see much more coming within the healthcare, from the healthcare system in the coming years. Also important in this movement towards improving population health are the use of various tools. And one in particular that's gaining popularity here in the United States are health impact assessments. Now, health impact assessments, or HIAs, as they are commonly referred to, have a long history in the international community. But it's only been within the last 5 years that they've really gained traction within the United States. And what health impact assessments do is that they increase the recognition that policy decisions that are being made in other sectors that are not traditionally connected to health, sectors like transportation, housing, education, et cetera, that all of these policy decisions in those other sectors have implications for health, and that before our key policymakers go ahead and pass a policy, that it would behoove them to understand what the health implications of those policies are. So it's an analytic tool that examines the health impacts and makes people sit down and look and see and understand what the consequences for health are for the implementation of a given policy. And this picture highlights one example of how a health impact assessment was used, and it comes out of some work in Minneapolis, St. Paul, where they looked at a light rail project that was developing in a major corridor. And the original light rail project had a certain number of stops that was part of the original plan. However, as most things go, budget went over and they needed to trim budget and eliminate some rail stops, and they proposed to eliminate 3 rail stops. The problem? The 3 rail stops were within significantly underserved and underrepresented communities. So a group of advocates and researchers came together to conduct a health impact assessment and show that the elimination of those 3 rail stops would negatively, disproportionately impact the poorest neighborhoods in the area. And they were able to leverage this information to actually get the stops reinstated. Now, I'm sure it goes without saying that leadership is a critical component to improving population health. This is my wonderful mayor, Michael Bloomberg, who's the mayor of New York City, or not so wonderful depending on your perspective of him. He's been getting a lot of hits lately for what many are calling his approach to a nanny state in New York City. And it's his approach to a nanny state as it pertains to health policy in New York City. Mayor Bloomberg has benefited from working with 2 very, very strong health commissioners in New York City. His first health commissioner, Tom Frieden, is our current director of the CDC, and Tom Farley, who replaced Frieden once Frieden transitioned over to the CDC. And Bloomberg has been a staunch advocate and promoter of health policy. He was the first in the nation to pass a ban on the use of trans fats within restaurants. He required, as many other places, menu labeling for restaurants, fast food restaurants and chains. We have probably the most comprehensive clean indoor air laws in the country, which also cover public parks and spaces. And he's increased within his tenure the amount of walkable spaces in New York City, much to the chagrin of all the drivers and the cabbies in the city. Now, this picture is actually a picture of one of his latest efforts, which was met with significant opposition and was actually squashed. His attempt to limit the size of beverages that people could buy at any one sitting to 12 ounces. One of the things, although he was not successful in getting the beverage size ban passed, he did raise onto the radar this issue of empty calories. And so it's going to be interesting to see whether or not he's going to be able to, excuse me, pass what he was trying to do several years ago, which also failed, which was a tax on sugar-sweetened beverages. Now, again, some people love him, some people hate him, but many do attribute New York City's health improvements and life expectancy to some of the advances that New York City has made as it pertains to health policy. And in just last year, New York City's health life expectancy was 2 years higher than the U.S. national average. Now, again, Bloomberg is just one example of the many leaders that we know get what it takes to improve population health and get that investing in the well-being of the places that they lead actually makes for good leadership and good policy. But I would argue that leaders really cannot lead people who don't realize what matters for health, which is why efforts to increase awareness are also an important part of implementing and improving population health. And this example comes from the California Endowment, which is investing $1 billion over the next 10 years to transform 14 communities within California through their Building Healthy Communities initiative. And a critical component of the initiative is their Health Happens Here exhibit, which is aimed at challenging popular notions of where health happens and actually how health is impacted. Now, again, this work is critically important because we won't be able to obtain a groundswell of support for improving conditions that fall outside of the health and healthcare sectors until individuals outside of our respective fields, or I would argue sometimes individuals within our respective fields, understand why and how these other factors that fall outside in health and healthcare matter for our health and our well-being. And the Robert Wood Johnson Foundation also has a similar initiative called the County Health Rankings and Roadmaps, which ranks counties within each state of the country on both health determinants and health factors. And again, meant as an opportunity to open up a discussion and dialogue about the fact that health does significantly differ by place, and tries to get policymakers and key decision makers to understand excuse me, why that is. And last but not least, I would say that a critically important element, thank you, to promoting population health is the importance of partnerships with folks particularly that we wouldn't always necessarily associate with health, but that we know, again, given all the factors that we know matter for health, are important for us in order to move the needle. Now, just in the last few years, the Robert Wood Johnson Foundation has engaged the National Business Coalition on Health, the United Way, and the Federal Reserve to understand how it is that we can all work together, again, with the goal and the purpose of improving the nation's health. And I would say that to make these partnerships successful, we really need to understand and accept and come to terms with the fact that our motivations for coming to the table may not necessarily be the same, but that's okay if the end goal results in better health outcomes. Sorry. So for example, the National Business Coalition on Health, they're at the table because they're representing the business interests of their members. And so for them, investing in efforts to improve population health is really a strategy to improve their members, who are businesses and companies, their members' bottom line. With the Federal Reserve, who invests billions and billions of dollars in community development, we're working them to understand how it is that they can expand their lens to community development and include one that focuses on population health outcomes. And with the United Way, who is, in case you didn't know, the top fundraising charity in the United States. In 2011 alone, they raised close to $4 billion, which is more than double the number two. The United Way, within the last few years, has streamlined their focus to income, education, and health. And so they make for a very natural ally and partner in our work. And so we're working with them and their affiliates to help them understand how they can more strategically deploy the wealth of their resources within communities, again, with the goal of improving population health. So I've walked you through some great things, and again, probably in the Q&A, I can go through more and more examples, but I had to take just a snippet of key things that touched upon key themes. But the whole goal and purpose of this was to show that although we definitely have some huge challenges in the work that we're doing, there are some really great strategies and solutions that people are implementing in the field that can help us move the needle towards improving health overall. And while I've walked you through some of what's currently happening, I want to shift gears to discuss a couple of things that are emerging that can hold promise, I think, to furthering our knowledge on how it is that we can approach this work of improving the health of communities. And the first one comes from the field of neuroscience. Yes, I know, I'm sure you're wondering, what the hell does neuroscience have to do with a very macro topic as population health? So just bear with me for a second. Now, it's been exactly a decade. In 2003 was when scientists first cracked our genetic code. And in this time, we've learned that while it's true that the DNA that we inherit from our parents is fixed, and if there are any flaws in the DNA, we have nobody but our parents to thank for that. What isn't fixed, however, is how our DNA is expressed. And there's a whole field of study that has emerged within the last decade called epigenetics. And we've come to learn is that genes are turned on or turned off depending on our accumulated positive and negative experiences in our environments. And that the nature of these experiences can have either temporary or long-lasting consequences for how we develop, which is especially relevant for the brain, which is highly influenced by our experiences in our environments early in our development. Now, if our environments are set up to promote positive development, then the likelihood of having the right genes turned on increase. However, if we're not lucky enough to be in those types of environments, then it becomes that much more difficult for our brains to develop in the ways that they should. And I just have a small video right now that illustrates the impact of environment, and in this case, the impact of a stressful environment on our neurological development.
Learning to deal with stress is an important part of healthy development. When experiencing stress, the stress response system is activated. The body and brain go on alert. There's an adrenaline rush, increased heart rate, and an increase in stress hormone levels. When the stress is relieved after a short time, or a young child receives support from caring adults, the stress response winds down and the body quickly returns to normal. In severe situations, such as ongoing abuse and neglect, where there is no caring adult to act as a buffer against the stress response stays activated. Even when there is no apparent physical harm, the extended absence of response from adults can activate the stress response system. Constant activation of the stress response overloads developing systems, with serious, lifelong consequences for the child. This is known as toxic stress. Over time, this results in a stress response system set permanently on high alert. In the areas of the brain dedicated to learning and reasoning, the neural connections that comprise brain architecture are weaker and fewer in number. Science shows that the prolonged activation of stress hormones in early childhood can actually reduce neural connections in these important areas of the brain at just the time when they should be growing new ones. Toxic stress can be avoided if we ensure that the environments in which children grow and develop are nurturing, stable, and engaging.
Just to let you know, the video comes from the Center on the Developing Child out of Harvard University, which has some great resources, again, between the connection of early environment and environmental exposures and later development. So again, why should public health care about these advances in what seems to be very micro experiences of neuroscience and epigenetics? Well, I would argue that it's these advances in these technologies and in the science enables us to understand how our cumulative exposures in our environments really gets under our skin and impacts our development, our ability to learn, our emotional well-being, our ability to regulate emotions and engage in social and healthy interactions, the likelihood of engaging in the juvenile or in the criminal justice system, and the risk for chronic illness later in life. And many would be rightfully so in saying that actually social science for many years has been examining and looking at the relationship between early exposures and poor health outcomes later in life. But finally, we have the hard science that really gives us a clear understanding of why it is that, or how it is that these factors, again, get under the skin, and why we see the patterns of poorer health, particularly for certain populations in our country, which strengthens our call to action to address the root causes of social problems, to again, prevent problems from developing later on. So in the same way that there's a lot that we can learn from neuroscience, or at least leverage, I should say, learn and leverage from neuroscience, there's a lot that we can also leverage from the field of behavioral economics, which simply stated examines how it is that choices and decisions are made, which we all know, for those behavior intervention folks out there, play a key role and impact our health and the quality of the care that we receive over time. Now, an example of this science comes from the work of Richard Thaler. How many of you have heard or read the book Nudge? Okay, a handful. Now, in Nudge, Thaler breaks down the science, again, of how we make choices and presents strategies on how it is that we can make better ones. Pretty simple. And Thaler talks about, not necessarily in the book, but at other places, talks about how when he was teaching, he observed that gut instinct among his students trumped logic. Now, these door handles, just to let you know, when you see door handles with pulls like this, our instinct is to do what? Pull, right? Now that's our gut instinct, however, right? But what he found was that students who tried to leave his classroom that had door handles like this actually tried to pull the door. But logic tells us that whenever we're leaving a major space like this, the doors open outwards, right? So if we understand that in situations, gut instinct trumps reasoning or logic, then what behavioral economics tries to do is tries to leverage the science to understand how we can structure our environments in a way that tap into these unconscious elements of our decision making to produce the choices and the decisions that make health or that result in healthier outcomes. And just one fun example of this comes from Stockholm, where they took an ordinary flight of stairs and added some whimsy to them in the form of a keyboard, which simply just plays notes when you step on the stairs. And what they found was that this small change, which did not involve educating individuals about the importance of physical activity, didn't require them to alter significantly the physical space, actually resulted in a 66% increase of individuals that used those stairs. Now, again, a relatively small change that tapped into the unconscious impulses. Imagine if we could leverage this on a larger scale. Now, before I wrap up, I did say I was going to tackle an elephant in the room, which I haven't necessarily touched upon my talk, but I think that needs to be addressed if we are to achieve some real long-lasting improvements in health. Now, I'm sure I saw that there were some really great quotes on the tables, and I'm sure this is one of them. in which Dr. Martin Luther King Jr. said that injustice in healthcare was one of the more shocking and inhumane forms of injustice. And although many of us can point to the fact that we've made some significant progress as a nation, our health profiles, however, would beg to differ. We have long and entrenched racial, ethnic, and income disparities, or inequities, I would say, that are getting worse and that cannot be reduced to individual choice or individual circumstance or cultural differences between groups. And as demonstrated in the book The Spirit Level, Wilkinson and Pickett's book, when we look at the relationship between health and social problems and income inequality, we see that health and social problems are worse the greater the income inequality gets. And lo and behold, where's the US? Right there, right on the top, or the bottom, I should say, whichever way you want to look at it. And unfortunately, we know that racial ethnic minority groups bear the double burden of our historical legacy of oppression due to race, which translates to and combines with a disproportionate representation within poorer income groups which suffer from this income inequality. And why is this even significant? Well, the proportion of our nation that's made up of communities of color is increasing. This graph shows the number of counties that had 40% or more of their county composed of communities of color. And the census reported that just in 2011, just 2 years ago, it marked the first year in which the majority of births in this nation occurred to women of color. And so we're expecting that by 2030, the number of community colors, again, counties with communities of color over 40% will start to significantly increase and eventually tip over. So again, all of this is to say that if we do not, as a nation, make a conscious and concerted effort to improve the lived experiences of Black and brown people, that will become the lifeblood and the economic engine of the United States, we're going to be in some major trouble. So is this a heavy lift? Of course it is. But I don't think it's anything that geniuses like those of you in the room cannot tackle yourselves. So with that, I thank you and open it up for questions.
Thank you, Dr. Henry Sanchez. We have some microphones that are in the back, so if you want to raise your hand, we'll get a mic to you. And this might be also an opportunity for anyone who might be standing in the back. We have chairs right here in the front.
Don't be shy, we don't bite. I stunned you all into silence. Come on, somebody challenge me, yes.
Of General Electric Company. My question to you is, what can we learn from the other developing nations who have significantly lower healthcare expenses than we do and significantly better health outcomes than we do, including some of the countries in the last slide that you showed where there are income disparities, maybe not as great as there are in the United States, but if I looked at that chart quickly, Portugal and the UK were pretty far up the scale.
Yeah. What we tend to see internationally is that a lot of those countries that, even though they do have income inequality, they tend to have a much broader safety net than we do here in the United States. The concept of universal health care is not foreign to them. We just passed it, 3 years ago? So that's a major driver and contributor, not only in terms of provision of access to care, but also just overall the broader safety net that says that society will accept poverty only at a certain level, whereas here in our society, we accept all levels of poverty and inequality. Also, I think the other challenge that at least people in the US like to point to is that our country is much more diverse than a lot of these other countries, and so there's still a lot of work that still needs to be done there. And when you pull and peel back the numbers in those countries, although they are doing better, they still suffer from the same kind of disparities within groups. So I think there are things that we can learn from better safety net, obviously improving our access to care, but we still have a challenge when it comes to improved outcomes for the populations that really need help.
Thank you.
Right.
Thank you, Dr. Sanchez.
There was another question.
I think we have time for a poll everywhere question. Renee? Again, text code 22333 is the phone number. So 31%, oh, it's changing. So, right, the decrease in the rate of obesity is in the lead right now, followed by increase in high school graduation rate, fewer uninsured people, decrease in tobacco use, better managed end-of-life care, increase in the employment rate. Dr. Henry Sanchez, what do you think about that? So, thank you. That was interesting. So, I think we're back on schedule. I think we're good. I'm going to just mention one more time before we invite our next speaker. If you're standing in the back or if you're sitting in the back and you'd like to come up front, we have 2 rows that are empty and waiting for you. Okay.